Welcome everyone to today's webinar, Embracing the COVID-19 Disruption, Leadership Perspectives on the Future of Acute Care, sponsored by Vitality. I am Brian Zimmerman, the Custom Content Editor with Becker's Healthcare. We'll begin today's webinar with a panel discussion, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And I'm pleased to introduce our panelists. Dr. Teo Corey, President of Vitality, Dr. Denise Brown, Chief Growth Officer of Vitality, Rick Rawson, President of Adventist Health and Rideout, Dr. Joanne Roberts, Chief Value Officer at Providence St. Joseph. It's a great group. We're really excited to dive into the conversation. And just to give an overview, today's discussion will focus on the future state of healthcare delivery and how health system leaders can transform hospital culture and foster innovation in care delivery. Our panelists will discuss their vision for what the healthcare infrastructure of tomorrow will look like, along with examples of new models of care delivery already in use that exemplify a long-lasting and positive impact on quality, accessible care. And so with that, we're going to dive into our questions, this panel discussion. And the first set of questions here really focuses on our panelist organizations. And Dr. Brown, I'd like to start with you. So the first question I have here is, what has been the most surprising impact to your operations as it relates to COVID-19?
Well, thanks, Brian, and thanks for making me kick it off. I think the most surprising impact has been kind of twofold. Number one, that we were more ready than we thought we would be. But the most exciting thing has been our ability to pivot and be agile and be quick about it. And I think that was something that was a little unexpected. So I try to look for things, the silver linings in all things. And while this has been a devastating both economically and medically for many people, what it's given us the ability to do is some of the things that we've always kind of talked about doing and always wanted to do, but either just couldn't figure out how to get out of our own way and make it happen. And so suddenly we had no choice but to make it happen. And our frontline providers were constantly saying, we've got to do this, we've got to do that. And we were able to iterate so quickly, whereas it might have taken a week or two to get a meeting scheduled, all of a sudden we were doing stuff and it really helped. And then when it didn't help, we changed it. And so that's something that I really felt like kind of came out of the blue, although certainly it was there, kind of maybe hiding and came to the forefront. And I just really hope that as we kind of move into whatever comes next, that we don't lose that ability to really be as agile as we can be, because it's been absolutely amazing to watch.
So really about keeping that momentum up, right? Everything that you all have been doing that's been maybe a long time coming, but now you're finally getting there. It's like keeping that momentum moving forward. Is anybody else feeling the same way?
Yeah, like I just can think of, we've done, I'll take telehealth as an example. We've done some telehealth stuff, where we're doing urgent cares and call-in clinics and whatnot. But all of a sudden, when either we're shutting down emergency departments or we're asking people to stay home, and we've got to come up with new ways of delivering care, because it's not like people aren't still getting sick. I mean, you still have diabetes, you still have heart disease. How are we going to deliver care in a different way to suddenly be able to kind of be like, holy cow, we've got to do this, and we can't kind of decide how to do it perfectly. We just need to go out and get it done. That to me was really exciting, and I hope that we keep moving that forward, because so many clinical ideas came from our docs and our nurses and people who were kind of in the thick of it, and that has helped educate those of us who weren't maybe in the thick of it at the beginning, but are kind of getting into the thick of it now.
Sounds like it really gave you all license to act. And Dr. Roberts, I want to get you involved here. So the next question I have is, so during this pandemic, how has your organization evolved its approach to leading change?
Sure. Much like Denise, I would say that we've never seen a burning platform like COVID is a burning platform for change. Really, I don't think it's changed what we see in our leaders, what we expect in our leaders, but I think how our leaders able to move faster has been really the change that we've seen. At Providence, Rod Huckman, our Chief Executive Officer, says that leaders have three attributes: a compelling vision, the courage to tell the truth about what's going on, and giving power away to the people who are actually doing the work. And I think all of those came to play during the acute ramp-up of COVID. We had local huddles, we had unit daily huddles, or even multiple times a day huddles. Because issues like PPE, testing, moving ventilators around across the system, across 6 states like Providence serves, we really had to go to a system daily huddle, to regional daily huddles, and that has created a tremendous way to move change quickly. When everybody is on call, 250 people are on system-wide call every morning talking about these issues, people get on board really quickly. And the third thing I just wanted to mention is Rod has talked about how did we ramp up our virtual care 100-fold, and how did we move 7,000 doctors in one day onto virtual care platforms. And I think we did that because leaders got out of the way. People had been working on these things, like Denise said, we've been working for 3 years. Virtual care had been moving at a fairly slow pace. Suddenly, we just had to get people out of the way, let the clinicians do it, and we were able to do it. And we're continuing to be able to do that. That level of virtual care that we never dreamed we would be doing at this point.
It's impressive. And for me, though, I think you cut out at the end there just a little bit. So I wonder if you can review. Everybody else might have gotten it, but I wonder if you could review that third point just one more time. I want to make sure folks got it.
So it's leaders getting out of the way. When work that is already underway is moving along fairly slowly, there's an urgency, a real public health urgency to growing virtual care quickly and at a scale we never imagined we would do. Our business leaders said, do the right thing clinically, we'll get out of the way, we'll figure out the business aspects on the back end, which has been great.
Joanne, can I just ask you, sorry, Brian, can I just ask Joanne a question? I find this really fascinating.
Absolutely.
Did you feel like some of the kind of like, inter-regional rivalries and, those sorts of things that typically kind of exist, even though we like to pretend that they don't, did you kind of see that kind of blow up and it was sort of all for one and one for all? Because that was another thing that I felt like
yes,
I sort of noticed.
Absolutely. Yeah. And I would say during February, March, and April especially, all of those silos just went away. Now, as we've moved into a steady state, we're seeing some of that siloism coming back, and that's the current challenge, is how do we keep those silos down and focus on, let's just deliver the outcomes that our patients deserve and not worry about who gets the credit or who's going to own the process.
So I want to open up that question again to the rest of the panel, give everyone else a chance to weigh in. So during this pandemic, how has your organization evolved its approach to leading change? I would really love to hear from everybody on this.
Yeah, this is Rick Ross, and I think there's two elements of this. One is how do we lead change internally, and how do we lead change in our community? And I think on the first element, like Joanne said, Denise also mentioned this, our agility has improved dramatically. We've gotten rid of a lot of our old structures. And when this first started, we went into a complete incident command center emergency response. And what we found in that process was the ability to process information very rapidly, to be much more purposeful and intentional about how we did things. Because we were doing all our huddles, we couldn't get people in the room. So we started using virtual, we use Microsoft Teams and virtual meetings. So all of a sudden, we're not having to walk from meeting to meeting. There's not transportation issues. Things are very prompt. Everyone's on time, and it's really worked well. And I don't want to go back to how we did it. And I think part of this evolutional opportunity is really how do we learn and become much more intentional and purposeful of how we build new structures and how we leverage technology. I think this blew up a lot of our old assumptions about how work needed to get done. We find that people are effectively working from home over a long period of time. That puts our whole real estate investments in a different light. If we can leverage that using technology and we can be effective and timely and agile, why not keep doing that? Our administrative processes are more back-end structures, where before, if an important issue came up, to get all the right people could take a week and a half getting it scheduled. It's likely we could get that done this afternoon or tomorrow morning, just because of the flexibility we have. So that's been significant. I think externally, especially with this resurgence that we've seen in California, I think we all went into sort of crisis mode in March and April with fairly devastating results. And I think we're taking a much more balanced approach. But one of the things we found in the last few weeks is that the public health structure is ill-equipped to really deal with behavioral issues in the community. I mean, this is something that's really preventable. It's based on people's actions. But there's something in the American spirit when orders or issues come down from on high, whether it's the governor, whether it's the county public health officer, that liberty and freedom wants to rise up and assist. And we've been watching our elected officials really getting pulled between the conspiracy theorists and business owners who are very loud, with a large number of the population that's quiet because they don't want to get shouted down, who's very concerned. And we felt that our healthcare leaders needed to weigh in to help balance this out, because a lot of people are out there saying this really doesn't exist. It's not happening. Why should we be concerned? So we put a letter and got basically all our competitors and all the leaders in the organization to sign a letter that went out last week to almost overwhelming response in the community, just because we felt we needed to weigh in that this is real, we can do something, and it's not an act of compliance to wear a mask and social distance. It's an act of compassion. And I think that's helped change the narrative in our community. I think that's the kind of leadership that is more of a grassroots leadership that we found we could do, where I think the other structures that have been trying to manage into significant resistance.
Yeah, I find it fascinating. I think based on your response there, like the pandemic has sort of shed light on externally some stuff that doesn't work, right? Like public health and behavioral health, those issues, society at large, and then issues internally, right, with processes that don't need to be around, or approaches that might be outdated. I'd love to hear from Dr. Corey as well, if you want to weigh in here on sort of how has your organization, how's Vituity evolved its approach to leading change?
Yeah, I think everyone's really touched on a lot of key points. I think all of us pretty much experience it across the various organizations. The only thing I would add is what we found is leading change doesn't always mean having to be led centrally. Leading change can actually take place at a local level. And what we found is, which really isn't surprising, a lot of our providers who are being faced with the various challenges also have the solutions, and it's really getting out of their way to allow them to implement those changes. We found a lot of some of the very innovative ways of adapting to this pandemic and adapting to the new challenges and hurdles is taking place at the local level, where providers have ideas and always really had been engaged in the past, but even more so now, getting out of their way and empowering them, giving the capabilities to implement their ideas, working with their hospital clients at the local level to implement those changes. So recognizing that solutions aren't evolved or developed in a boardroom or in an office somewhere. The best solutions frequently come from the frontline providers. It's about empowering them and giving them the ability to implement those changes.
Appreciate that. It makes a lot of sense. Solutions sort of coming up from the front lines there. And then, so Rick, I want to turn to you to kick off this next question. I think you talked a bit about sort of your public officials having to manage a tricky balance. I think there's a tricky balance that hospitals are certainly having to wrestle with, and providers. So how are you managing the risk of future surges against the decrease in patient volumes?
Well, I think I can't say we're seeing a decrease in patient volumes right now. I think really, we've seen much of that volume come back. Now, March and April, we basically shut everything down. We canceled all non-urgent surgeries. We shut down our clinics that were seeing over 400 visits a day in this community. So a lot of that shutdown, telling people to stay home, not come, we saw a significant and really a catastrophic impact financially to the business. And at the same time, we were building up for this capacity surge that we knew could not come, and there was cost associated with that. So it was really a perfect storm. And I think it became clear that that was not a sustainable way to really address this, because there aren't many of us that would still be in business for very long if we pursue that as a response to the pandemic. So I think we've come with a much more balanced approach now. We brought these things back. It's still creating capacity issues. Our post-surgery unit, our PACU has, distance limitations, which almost halved our capacity, yet we're trying to drive the same number of surgeries through there. So there's a lot of adjustments that are happening to balance the capacity issues we have. At the same time, we did not do the best job taking care of people with other acute issues that were non-COVID related. Our ED director and I were sitting there thinking, we were doing about 200 visits a day in our emergency department, and we went down to 100 a day. Now, you could argue 20 may not need to be there, but what about the other 80 people? Who are they? Where are they? How do we connect with them? In fact, when we saw our ED volumes come back, we probably saw in a 1 week period the number of STEMIs we saw in a 2 month period before. We were seeing people coming in with strokes that should have been in much, much sooner and having deficits as a result of that. And we did a lot of outreach. She and I got on the radio letting people know it's safe to come in, because I think there was a lot of fear in the community. But then, our ED provider is Vituity, and this is an example of what Teo said in terms of local leadership, because when she and I are asking the question, how do we connect to these people, we ask, what can we do in ED at home? And it turns out the innovation part of Vituity had been working on platforms to find out ways to connect to people at home. And we think this could be a really sustainable way of actually improving access to emergency care and better coordinating capacity in our emergency department on a long-term basis. But again, that was a local leadership that was supported by central structures in terms of meeting needs of patients. And so I think we continue to balance this. Every day we're looking at our capacity, we're looking at our supply chain, our pharmaceutical supply chain. Testing capacity is still an issue. So this is an everyday process. So there's elements of our incident command we've kept virtually in place. and have daily huddles on that. But it's balancing this issue of capacity and volume every day, be here for the community when they need us. And if we see more surges, which we expect, we've seen our COVID patients triple just over a weekend. And we have to be ready for that because we think that will continue going forward.
So, Rick,
Dr. Brown, you're very small on my screen, but sorry, go ahead.
Yeah, this is Joanne. I just wanted to follow up on what Rick was talking about, and he reminded me that this requires a real strategic view of leadership. Our experience was almost identical to what Rick is talking about, and so when we were seeing the first wave spike in the Seattle area, we had a team already looking at how are we going. We know we're going to be shutting down. We have to save PPE, that we have to flatten that curve. So how do we start thinking about reopening once we have shut down? So we had a team of leaders starting on that even during the first wave surge. And now that team is looking at how are we going to handle the flu season. So I think thinking 2-3 months ahead as best we can to try to be ready for the next event that's going to come our way.
Brian, I was going to say that, some of what Rick was talking about with the programs that we put in place in terms of doing not only ED triage, but also initiating emergency care from home that we've developed and implemented at hospitals like Rick's and many others, I think is exactly kind of the idea of being ready for whatever comes next. Everyone keeps talking about a post-COVID world, and I think we in healthcare can all acknowledge that there is no such thing as a post-COVID world, right? There's life with COVID and whatever comes next. And so how do we adapt our quick and rapid learnings to make sure that we're poised to do whatever comes next? And when flu season does hit, how are we going to do that? And some of the stuff that we've been able to kind of put together in response to this crisis actually sets us up to really be able to deliver better care to more people in our community, no matter what, whether it's COVID or not COVID or flu or not flu. And that to me is, I think, the ultimate silver lining in all of this, that if we can kind of continue to bring that forward. So the idea that we are about meeting people where they are and taking care of them where they need to be taken care of, rather than the sort of, oh, you come to us and the kind of more paternalistic kind of view, quite honestly. I think that we sort of knocked that Humpty Dumpty off the wall, and that's something that actually really excites me. So the idea that we can interact with people in a different way, and then where do you take that next? And how do you deliver care to those who are woefully underserved, to folks who either don't have access to care for a variety of different reasons, or are homeless and living on the river, right, Rick? That to me is that's what we should be spending our time and energies thinking about, how to do more of this. And it's actually really exciting, I think.
Yeah, it makes a lot of sense to sort of expanding and making that change to increase care accessibility. And I think the phrase I've heard before, I think it was probably you that said it actually, was like the transactional nature of healthcare, right? Like that's really what the next step is.
Yes. And I think this is a great leap forward into really making sure it's about relationships. And I think Rick is the master at relational medicine. If it's my phrase, Brian, it's actually because I stole it from Rick.
Good to know. Good to know. Proper credit. Got it. Dr. Corey, would you want to weigh in here before I move to my next question? If you want to just build on anything your colleague said or any of the other panelists.
No, I think everyone really hit on all the key points. I think we need to all recognize that we're not going to be able to predict where this is going to go from here. I hear that we're going to see some surges, and as a result of surges, we're going to start shutting things down, and volumes are going to go down again. But then when we look across the country and we have exposure to various regions, we're seeing a variety of changes taking place with volumes and surges, where some areas surges are taking place and volume is going up. In other areas where they're shutting down, volumes are kind of trickling back down. So I think it really goes back to not trying to do things centrally, not trying to plan centrally, and recognize that we're going to need to be nimble and we're going to need to have engaged providers, engaged leadership at the local level, looking at their communities and seeing what are their local challenges and what are their local opportunities and implementing them that way. If we try to predict everything centrally, I think we're going to be caught off guard. The other is what I wanted to highlight that Denise pointed out is that there's no such thing as a post-COVID world. This is our new reality. The real question is, how does it evolve over the next 12 to 18 months? I don't think this is going to go away in the next 3 or 6 months or so. But we also, as a healthcare sector, need to think beyond what's taking place now. A lot of the solutions that we have put in place today that are helping us in the short term, we need to think about the long term. How do you continue to evolve these solutions so that it really benefits healthcare and our patients in the long term? And by that, I mean that one of the concerns we have is that although we're moving things in the right direction where we're moving care to the patient, one of the risks is that we start to lose that integration that we had been working on for the last 5, 6, 8 years or so. If we don't continue to evolve with a long-term in mind, there's a risk of regressing to a more fragmented system. So we need to keep that in mind as well, that we are providing and creating solutions that are integrated so that we continue to deliver the best and most effective care to our patients.
Yeah, it sounds like really, like fixing some of the inefficiencies that have been existing while also keeping the stuff that has been well achieved and established, like the integration you're talking about. And I think I want to pivot here to talk a bit more about the role of clinical leadership. And Dr. Corey, we can stick with you just to kick things off, and then the rest of the panel can weigh in. So what is the role of clinical leadership in the transformation of care delivery?
Well, picking up with this last discussion, I think it's pretty obvious with everything that we've been through in the last several months that the imperative to develop innovative approaches to patient care delivery has never been more critical. Over the last 6 to 8 years or so, with a push for value-based care, in many ways we've seen healthcare change dramatically in a very short period of time. But at the same time, not much has changed in healthcare, and I think we saw a lot of that lack of needed change in the last few months. But many of us believe that change is going to accelerate as a result of this pandemic, and many of the ideas that we've had of how care can and should evolve that didn't catch on for various reasons are now seen as obvious solutions that need to be implemented. So I think the pandemic has been a catalyst to accelerating change. And so to your question, the role of clinical leadership, it's really going to be that bridge between what the care is today to what the care should be in the future. And really tying into a little bit of the discussion earlier, I think it's important to recognize that providers really have a front seat view of the current gaps in care, but they also have a front seat view of what the potential of what tomorrow's care could be. And so regardless of how the new care modalities are created, providers will have to execute them. And so to me, the role of clinical leadership is to create an environment that invites, that encourages, that engages providers to participate in the transformation of care. The transformation of care doesn't take place, as I said a little earlier, in a lab or in a boardroom. It takes place through engaged stakeholders finding solutions to problems that they face really every day. And the clinical leader's role is to create that environment of engagement, create that culture of innovation that will bring those solutions to life.
Yeah, something that's helpful for me that you said that it's helpful for me to picture that is right, thinking about them as the bridge to this better place. Does anybody else have anything they'd like to build on there? Any additional thoughts about the role of clinical leadership in driving a care transformation?
Well, this is Joanne. I think one of the things, this is a bit granular, but one of the things we notice, we have tremendous clinical leadership across Providence, and they've been on the forefront of the broader response. One of the things that's fascinated me is our specialists during the first wave, and we had to shut down so much of our elective surgery, we had specialists sitting idle. And during that time, many of those specialists re-looked at how they could deliver care in a different way when things started coming back. And so the amount of specialty virtual care now has skyrocketed with primary care, because I think our specialists are open to new ideas of ways of caring for patients. And we're finding, we've all been talking about robotics for decades, about the potential for robotics. Now we're talking seriously about remote robotics as a way of delivering some procedural care.
I'll jump in, because to me the clinical leadership is, again, I think many doctors have felt somewhat alienated from hospital administration over the last, let's say, 15 years, right? Ever since we started throwing EMRs in the mix, there's been a kind of a gap, an us versus them sort of mentality, where you've got a group of doctors who are like, well, I wish I could just take care of my patients, and those darn administrators just get in my way. And, having lived on both sides of that, I completely get it. This was, again, one of these times where that us versus them went away, and it really was just all for one. And that, again, is something that I think we need to try to cherish and to hold on to. But what it really, what I realized how we did all that is that, basically, at least in our organization, we try to have a common purpose, right? So all of a sudden, all across the US and really all across the world, we had this common purpose. So we have a shared motivation. And then we have to have an infrastructure that's set up for success. We have to have tools that people can tap into, like Rick mentioned. But then we have to give people the license to act. And I think that that's something that Joanne and the Providence team did so incredibly well, is that you did get out of the way, but you let Alaska do what Alaska needed to do, and you let Seattle do what Seattle needed to do, and you recognized that this is really a hyper-local event, even though it's global. And your ability to kind of create that shared motivation, that infrastructure that people could tap in for resource, but more importantly, the license to act and stay out of the way, I think is one of the things that I really enjoyed watching you guys. I mean, you were really kind of in it at the very beginning, so we all really learned from you. But I think that those are really the pillars of any kind of successful leadership framework, and I really just felt like you guys really demonstrated that.
Well, thanks, Denise, and it was very intentional and very necessary, I guess, because of the way things rolled out. That we knew, the Seattle area was going to be our first big wave, so the whole organization was structured to how do we help everybody else learn from what they're innovating with and dealing with in Seattle, and then it became California, and right now it's West Texas. So. It jumps around of where our local folks are learning. Our job is to help spread that learning across the organization quickly.
Fascinating stuff there. Appreciate everybody weighing in. And Rick, I'm going to send this next question your way to start, and then open things up to everyone else. So, Rick, how do you ensure that patient-centric care is at the center of your practice?
This is, I think, something strategically we've been aspiring to, as Denise mentioned, moving from really what has been a transactional business model for a long time to a relational business model where the care we provide is within context of the relationship versus trying to pour a relationship into a 20-minute visit or a 3-day length of stay. And this has challenged us to get beyond the walls of the hospital. Our business at acute care has been so driven by the capital investments that we've made. It's been an efficiency of use of our resources. And so patients have had to navigate in whether it's a chaos in the payer world, or and navigate that way, or even navigate their way to get the very necessary care that they need. It's been disconnected, and I think this gives us a unique opportunity to really redesign around the patient. And it's going to inform how we make future design decisions and how we make future capital investment decisions. I think no longer can we just keep building bigger towers and buying more expensive equipment. Those things need to be very purposeful in support of people. And where this gets a little uncomfortable for us is when we start getting outside of our walls and start moving upstream and moving into social determinants and moving in to the public health space. There's this sense that, well, this is not our business. But I believe what this has done, what the pandemic has done, is ripped the Band-Aid off of a problem we knew existed all along. And that was a dramatic breakdown between our acute care, provision of care, and public health. And what we find is our system is very poorly designed to really impact public health. It's moving to me and to watch doctors and nurses emotionally react to what they're seeing with this pandemic, because frankly, there's not a lot they can do with the tools we have. They're just trying to keep people alive, and I think sense of almost futility or lack of control really gets to the heart of it. And when in fact, if we move outside and move upstream, we have a lot of control on this. And that's why I was mentioning a little earlier that we started wading into the debate around public health behavior, because I take it personally, because my doctors and my nurses are on the front lines. They are the ones that are at risk if our community acts recklessly and don't do the things they need to do. And while we're here and prepared and ready for the surges, to be victims of this, as we've always been, if you look at what comes into our emergency room, much of it could have been addressed earlier upstream if we'd taken our responsibility to the community and to people who live in the community. Now I think it's imperative that we continue to build our competence, build our relationships into the community, and really begin to weigh in. And whether it's addressing homelessness, whether it's housing, there's a lot of impact we can make because we do have influence, and we've got to get outside of our walls and begin realizing that, our mission in a community is not just about providing the best care when people walk in our doors. It's about making our communities better and healthier places to live because we're here.
Rick, this is Joanne, and underscoring that the surveys that we've seen and even the ones that we've done has shown that no one is trusted more in this pandemic right now than doctors, specifically doctors. Health systems a little bit less so. Doctors sit at the top, and getting our doctors, inviting our doctors to stand out and lead the communities on issues like masking and social distancing is a place that I think we have to step into. We just have to, because no one else will if we don't.
Yeah, I'd like to jump in on that. I think you bring up a great point there, Joanne. And I think it was Rick that mentioned this earlier, or Denise, I can't remember who. Unfortunately, this pandemic has really been politicized quite a bit. And unfortunately, the patients, the public has really paid the price of this. There's a lot of confusion out there of what to do, what not to do. And going back to Denise's point of silver linings, I think one of the silver linings and what we've seen with this pandemic is it's really brought the local hospital systems and the communities closer together. You see greater communication between the hospital, the physicians and nurses, and their communities, whether it's through televised ads or whether it's through social media, whatever it is. And the patients, the public, need that connection because they don't know who else to believe, but they will believe their providers locally. And going back to the issue of engagement, and Joanne's point just now, it is critical more than ever that providers are engaged, not only engaged with our hospital leadership to develop solutions, but engaged with the public to guide the public of what steps we should be taking to manage this pandemic and whatever future health crisis we may have. And this goes to the point that Rick was making as far as the gap between acute care and public health. And I think there's an opportunity here for local hospitals to bridge that gap in leading their communities and through their engagement of providers at the local level.
And I think we can certainly take that beyond COVID, right? I mean, I think there have been huge gaps in care across America for many reasons, and we are the ones who can do something about it. So we, as a community of physicians and healthcare providers, we should do something about it. And I think this has been an ability for us to recognize kind of our own power and our own capacity to act. And so that's something I want to make sure that we continue to do, that we listen to our docs and we listen to the nurses and we listen to the people who are there laying on of hands, and we figure out how to go bring that care to the people who need it. Because as we see, the people who are most affected by COVID are those who have the biggest gaps in their care. And so the way that we move upstream is to close those gaps. And that, to me, is our social responsibility as a physician. I feel like that's my responsibility. And so I think this is unmasked that, and hopefully that's the kind of disruption that we need.
So this is Joanne again. And on this community voice, it goes back to clinical leadership to me, because in the past, we physicians, like many clinicians, we think we can fix it ourselves. And I think that's something that many physician leaders struggle with as they develop. I think that the recognition that we're all talking about here is to mobilize our communities, which means learning to lead through others, that really getting others engaged and invited into the dialogue. We're not going to fix it. We can help lead it. We can help with the science, but learning those skills about bringing others to the table and empowering them to act on behalf of their communities. I think that's the essence of one of the challenges ahead for us.
I'd like to reinforce that. One of the things I've done here, we do these virtual town halls, which is another great thing that's come out of this. Is that, I've always tried to do town halls, but you spend hours meeting at all hours of the day and you get 10% of your workforce, and it feels frustrating. But now, using virtual platforms, we're able to do live town halls that people can watch later, and we're able to get much better penetration. But one of the things that we've been continually reinforcing with our staff is we don't have to just be victims of what happens to come our way. We all have agency, and we all have influence in our families, in our neighborhoods. And, when you look at the number of employees we have in our organization, we have about 2,300 employees that live in these communities. When you start looking at the viral impact of if every person takes it personally to be able to go out and lead from where they're at, lead in their family, lead in their church, lead in their community, the impact we can have is much more significant. And I think we've put too much focus on administration as the mouthpiece of the organization. And I think we need to move much more to the periphery of clinicians and leaders that are out there, that are connected, that are frankly trusted more to be able to deliver messages and support them in how to do that. So thank you, Joanne. That was excellent.
Yeah, this has been a fascinating conversation. I think recent comments kind of point me to my next set of questions, which is sort of about the future state of hospitals. And I think the comments about live town halls definitely have to do with this, and some comments from Dr. Roberts as well. And so I want to dig deeper here. So how can hospitals differentiate themselves to meet the diverse and changing needs of their communities? And Dr. Roberts, I know you were talking a bit about this already, so I'd love it if you could kick us off.
Sure. I think we've all touched on this already, that we're going to be getting away from bricks and mortar. I have lived in Seattle for a long, long time, and there's this other company up in Seattle that we often refer to, and that's Amazon. And I think we live in an Amazon world. We have been living in an Amazon world, but we haven't been acting that way as a healthcare system. But I think COVID, oddly enough, I think COVID has required us to become customer obsessed. And that means delivering care where people are, when they need it, not on our schedule, not in our facilities. We'll always have acute care hospitals. We'll always need ICUs. We'll always need trauma centers. But we have to ask what in the hospital can be done as an outpatient. What in an outpatient facility can be done at home? I mean, that we have to keep asking those questions, because it's not just moving things out of the traditional hospital. It's also moving care out of the traditional medical group. And it also invites others to be part of that care, maybe even unlicensed people at some point. But I think the whole idea of a doctor and a hospital and a nurse being the center of care, it's antiquated now. And I think we all have recognized that. And the country's demanding more from us.
It makes a lot of sense. I think it's been a lot of talk for a long time about patient-centric care, right? But now this is like finally the last push to get it to where, like you said, you're customer obsessed. And I think I'd love to hear from Dr. Corey on this one too.
Yeah, I want to bring up something I mentioned a little earlier. I think, first of all, I think it's fairly clear now to everyone that moving to more and more virtual care is, it's a done deal. We're all moving that direction. The question is, how far are we taking it and so forth? The concern I have in this area, which I touched a little bit upon earlier, is as we move that care more and more virtually, there is a risk for fragmenting care once again. And so as we move forward in this virtual world, in this Amazon world, I think hospital systems will need to make sure that as clinical leadership, as we develop these solutions for the long term, we need to keep in mind, how do we do this in a way that keeps the care integrated? And in the past, patients have been easily lost within our systems. I could see them getting lost in our systems even more easily moving forward. And so patient navigation, I think, becomes even more critical in this new world. And there are ways to do this, very easy ways to do this, and scaling it in a way that is very effective. But as we move care more into the patient's home, even hospital at home, which some systems, as a matter of fact, Adventist Health is doing, how do we help manage these patients and make sure they're not falling through the cracks? So this goes back to a comment I made earlier. We're developing solutions for the short term to get us through this pandemic, but we need to keep the long-term in mind as well, and this is one of those key long-term factors we need to keep in mind, making sure that we're not fragmenting care and keeping it integrated.
Yeah, I actually, I'll tag off of that just for a second. I mean, I think we kind of, the doctor parts of us have to kind of like get over ourselves, and so we've always sort of like, you know what I mean? It's like, well, the doctor's the quarterback of the way. I mean, that's kind of like a bunch of hoo-ha, in the sense that if we're the coordination is really what's going to matter the most, the navigation, the coordination, like Teo mentioned. And so to kind of toggle back to what you were saying earlier, Joanne, I think we need to recognize that the healthcare team, if you will, is about more than the physician and the nurse or the pharmacist and the lab tech. It's going to be about peer navigators. It's always been about family. It needs to be more about family. It needs to be about community. Like, those are not parts of the puzzle that we've sort of decided to, like play with. It's been like, okay, well, this is the stuff over here that we do as the health system or the doctor's office. And then all of this other stuff happens over here. what real navigation and coordination means is we really all live under that same umbrella, and we all exist to kind of help create the health and wellness of this individual patient. And we do enough of those, and that's how our community gets healthier. So we really need to be open to people that we would kind of consider untraditional members of the team. And I think in terms of navigation, that's a great way to invite new people to the game. They don't have to be doctors. They don't have to be nurses. They have to be people who are willing to be kind of tireless in their efforts to essentially provide customer service. And that's how we're going to be able to keep all of this streamlined and keep it all coordinated. And I think that's the brave new world.
This has been a really great discussion. I want to go ahead, Rick. Then I want to get to some audience questions.
Yeah, I was just going to say, I think we need core design principles, and I think the principles around relationship and the principles around integration need to be center of how we design these new systems. I mean, when you think about it, virtual care provides the opportunity for both a cardiologist and a primary care doctor to be on at the same time with their patient, which is almost unheard of in terms of the way we do specialty referrals and care. That's, I think, where we can think about making patient centricity really about team-based care, because now technology gives us the ability to do it. And as leading a community hospital, my concern all along with virtual care has been the elimination of geographic boundaries, but there's something still very local about the relationships in a community. And I think it's really important that local medical communities embrace the platforms that are available to get into this space and provide these kinds of services, because others will, but when others do, so if you have people providing primary care globally or, into your community, what happens when they need a specialist? Where's the relationship there? What if they need a procedure? How does that happen? What if they need connection to social services? So we get back to fragmentation again. So I think taking those design principles of integration of how we do everything and set that up is critical.
Important point there. And I do want to, this has been a great discussion. I've got more questions for our panelists, but they've been wonderful. I want to make sure we get enough time to take some of these audience questions, because there's been some great engagement, some great questions come in. So I'm going to go ahead and kick it off with this one first. So this attendee asks, I'm interested in how you see hospitals being able to ride out cycles of their communities closing down and opening up over and over. In our county in California, we just closed up a lot of services again. This might have an impact, again, on our patient volumes. I'd love to open this up to everyone, but perhaps, Rick, you could start us off with that.
Yeah, we actually in our huddle this morning had this very conversation, is how do we support responsible behavior, yet at the same time show compassion for the business owners who are being impacted by these new orders that just went into place. And I really think it's about communicating more effectively how we be responsible to each other as a community. And, when I look at how we opened up the last time and the idea that people had, well, okay, now the lockdown's over, we can just go back to how we were. They didn't hear the last half of the public health officer's warning, is that can do these things if we follow these guidelines. That was completely lost on our community. And as a result, California is seeing an incredible spike in hospitalizations. We expect to see a spike in deaths here in the next couple of weeks. In our own system, we went from the height of the March and April of probably 120 COVID patients in the hospital. And just over a week and a half period of time, we went to 200, and now we're almost at 340 statewide. So this is growing very fast, and I think making sure we be consistent with those messages, we can have an impact and make a difference.
Perhaps one more person could weigh in on that, and then we'll move to the next question. Dr. Roberts, maybe, do you have anything to add?
Sure. Well, just to pick up on Rick's theme, I think it again underscores the need for clinician leaders to lead on that messaging. And I think it's very important for us to stick with the science and let our communities know this really is the science. And if others want to politicize it, they can deal with that. But I think our good reputation depends on us delivering a scientific message.
And I think the science tells us this is going to be a yo-yo, right? And so people want to believe that there is a pre and a post, because that's how our brains work, right? There was a before, then something happened, and now there's an after. And the idea that it's going to be like this is difficult for all of us to wrap our minds around. And it's difficult to plan for, and it's difficult, to figure out what I'm going to do with my kids when it's time for back to school. All of those things are true. And what we need to keep coming back to is the science and the compassion, and that science and compassion are actually the same thing, and that's what we need to demonstrate to our people, and so that, I think, is the way that we move through this, but we don't go beyond, right? I mean, 5 years from now, you'll be getting your influenza shot and your corona shot, probably. That's probably going to be the way that it is forever and amen. So let's not think about a return to before, because then that limits our thinking. It makes us less flexible.
Well said.
That's a great point. And the next question I want to take here, we've got a ton of great audience questions. It's really some great engagement here. But the next question is, has your organization seen an increase in utilization of telehealth by primary care practitioners to manage chronic conditions and thus prevent overutilization of ED and acute services? Dr. Corey, can you talk about this from the Vituity perspective?
Yeah, no, absolutely. We definitely have. We had created a platform more than 5 years ago, telehealth platform, and going to the comment I made earlier, a lot of us in the healthcare world saw solutions or believed in some solutions, but it just didn't catch on. And of course, this pandemic has really been a catalyst to accelerate a lot of change. And a lot of those solutions now that just didn't catch on as much before, all of a sudden have become real obvious solutions. And so one of the things we've seen is virtual care really skyrocketing. Not just in primary care or acute care, but even in some of the subspecialties. Mental health is really skyrocketing. It's an area whereby there is a great shortage of providers, and it's a great way to scale this resource across regions. And much needed, especially at a time like this. One of the things we're seeing is that although our visits have gone down in urgent care, emergency medicine across all diagnosis types, some of which we shouldn't have seen gone down, to Rick's point earlier. The one area that we didn't see really go down is mental health. We're going to see this virtual care being utilized much more. I think it's becoming more and more accepted by the patients, by the public, but along with it, we're going to need to continue to evolve how we utilize it, as I mentioned earlier, to make sure that we continue to make sure our care remains integrated as opposed to the risk of fragmenting once again. So we can't just rely on what we've put together so far. We need to continue to evolve it with the long term in mind.
Continued evolution, thinking long term. I think these are some themes that have emerged throughout the conversation today, and it's been a great one. And we do have just a couple minutes left, so I want to ask one more audience question. I think it's one that each of you could weigh in on, probably pretty simply here since we're near the top of the hour. But the attendee asked, what steps can you recommend to create a culture that fosters continued advancements to patient-centric care? And if we can just go around the clock here, each of you just giving a couple points on that one. Rick, we can start with you.
Yeah, I would come back to building that culture of design and using a customization approach to the patient. There's some people who are going to really gravitate to telehealth. There's some people that still want the personal interaction with their physician. And, versus what we've done in the past, have a one size fits all. I think we really have to be open to what the patient wants, how they want, and how we give them agency and empowerment back from the expert model that we've used for so long. How do we become their support and their coaches and taking ownership of their life and do it in a way that works for them?
Thank you, Rick. Dr. Brown, you want to go next?
What he said.
Great. What about Dr. Robbins?
Well, I'll come back to the Amazon example, which is saying the same thing that Rick just said, that we have to be customer obsessed. And I mean customer obsessed, not just patient obsessed. So our customer is our communities as well as those patients who are coming to us, and we have to go to them. If I can buy a book and get it this afternoon on Amazon, there is just no reason I should ever have to wait for a doctor again.
Excellent. Dr. Corey, final word?
Yeah, I think as clinical leaders, it's absolutely our responsibility to create a culture of innovation and a culture of engagement. And that culture that we implement as clinical leaders really needs to be focused around the patient, or as Joanne just pointed out, the customer. And I think it's innately within many of us providers, that's why we went into healthcare, is to care for our patients. So calling that passion back out as we call them to the table and get them engaged, that will naturally help us continue to keep the patient at the center of our focus. But we, as clinical leaders, it's our responsibility to create that culture of engagement and innovation so that we continue to plan for the long term.
Excellent. I think we've had some great thoughts to finish everything out here. So just want to thank all of our panelists. You all are great. It was an excellent conversation. And on behalf of Becker's, I want to thank Vituity as well for bringing us all together and giving us a chance to have this conversation. So, and also thank you to the attendees for joining us today. We hope you enjoy the rest of your day, and we look forward to having you join us for future webinars.
Right.
Thank you.
Well, thanks.
Thank you all.